the topic is basically it is a case of complex regional pain syndrome, and this case was following for how they presented and the case progress. So let's see how it goes. So I think Diya has to share the screen.
Diya has already shared screen, right, Dr. Diya?
Yes, ma'am.
Yeah, you may start now.
Good evening, everyone. First of all, I would like to thank the esteemed society to give me the opportunity and platform. I am Dr. Diya Aggrawal, Fellow Pain Medicine at AIIMS Delhi. I would be presenting a case of CRPS and how it progressed and showed pattern shifts in a longitudinal time frame. So the phase 1 started in 2022. A 58-year-old male presented to pain clinic 4 months following order for fractured distal end radius, which happened in February 2022 with the following symptoms. There was a severe electric current-like pain radiating up the limb with NRS 9 on 10. Right hand swelling was there. Patient had feeling of warm right hand as compared to the other, and the patient had fear of touching the affected hand due to pain. He was unable to move the hand due to pain and stiffness. On examination, there was swollen right hand with shiny skin. Allodynia and hyperalgesia was evident, which was more distally. Temperature asymmetry and color asymmetry was present, along with trophic changes in nails. And there was marked restriction of movements at rest. Now, routine blood investigations were normal, including vitamin D and B12 levels, except for ESR and CRP, which were raised. Now, at this stage, he fulfilled CRPS 1 criteria, which was consistent with Valencia consensus, which I'll be discussing shortly. Patient was educated about the disease to provide psychological support. Pharmacotherapy was started with gabapentinoids, vitamin C, and NSAIDs. And he was advised to start movements of hand gradually once the pain subsided. Interventions done. A series of stellate ganglion blocks in due course was given, followed by PRF of the stellate ganglion with adequate relief. To discuss the ISP diagnostic criteria, also called as Budapest criteria, with respect to the case being discussed. The patient, looking upon the symptoms presented in the category, patient had continuing pain, which was disproportionate to the fracture and surgery. The patient had pain on touch, feeling of warmer right hand, swelling, and restrictions of movements, which were all synchronous with the examination findings. Thus, the patient reported symptoms and had visible signs in all of the 4 categories. And no other diagnosis could better explain the signs and symptoms. A brief about the pathophysiology of CRPS. The figure illustrates the proposed mechanisms observed in CRPS, including afferent mechanisms such as inflammation and endothelial dysfunction, efferent mechanisms involving changes in the somatosensory and autonomic nervous systems, and central mechanisms such as cortical reorganization and psychological factors. Nociceptive and adrenergic neuronal coupling may lead to sympathetically maintained pain, while cortical remodeling occurs at the level of CNS. The consensus held in Valencia, Spain in 2019 brought CRPS experts to look at the confusion in the diagnostic text and how it is being used in clinical practice. And changes under 3 areas were agreed upon. The first area was diagnostic parenting under ICD-11. So CRPS was shifted from focal or segmental autonomic disorder to the chronic primary pain. Now the CRPS comes under chronic primary pain. Second change was done in subtyping CRPS. CRPS2, as defined in the ISP criteria, is associated with discrete peripheral nerve damage. And CRPS1, which is without discrete nerve damage, they have both identical diagnostic signs. And the group the clinical relevance and implications of subgrouping CRPS into these 2 subtypes remained unclear. Then a new CRPS subtype was introduced, which is CRPS with remission of some features. In these, the patients who did not fully met, the patients who have once fully met the CRPS criteria at one point in time, but now currently display CRPS features which are insufficient to fully meet the criteria, were put. The term CRPS NOS was reserved for those patients who have never been documented to fulfill the new ISP CRPS criteria. And now they display some but not all features, and no other diagnosis better explain their clinical features. Next, they said that warm, cold, or early persistent CRPS are overlapping presentations that are clinically observed. And they said that there is insufficient evidence as of now to create formal CRPS subgroups according to these subtypes. Then there was a discussion on when to say that CRPS has long been standing and when CRPS has to be set persistent. So the duration for persistent CRPS was defined as the CRPS which is lasting for 12 to 18 months after onset. And the word chronic was replaced with persistent. The second change was under the diagnostic procedures. They said that all patients should be systematically examined for the symptoms listed in the criteria at each formal visit because CRPS signs and symptoms are clinically observed to fluctuate over time. Second, they clarified when to use the terms asymmetry and when to use changes. For unilateral CRPS cases, we need to assess asymmetry, and for bilateral and symmetrical cases, we need to assess changes in the affected limbs with relation. They said that the full diagnostic criteria must be applied to each limb individually, and where the extension of pain alone to other limbs is not considered to be spreading CRPS. Now, with all these changes, they said that there is a future scope for research as to whether CRPS type 1 and type 2 are indeed separate entities, whether introduction of further subgroups such as warm, cold, or early persistent is useful, and whether the utility of biomarkers is there for supporting the clinical CRPS diagnosis, and how to define resolved CRPS. This was the Valencia consensus. Now, after Valencia consensus, which was published in 21, and updated evidence on CRPS, published in 25, emphasizes phenotypic classification based on the most prominent underlying mechanisms. Soluble interleukin receptor 2 may help identify inflammatory mechanism. Quantitative sensory testing identifies nociplastic, and thermography is used as helpful for vasomotor asymmetry. And depending on the subtype, management can be guided accordingly. Like bisphosphonates are effective in inflammatory subtype, while ketamine can provide pain relief for the nociplastic or neuropathic subtype. Sympathetic blocks are effective in addressing vasomotor disturbances, and for patients with refractory symptoms, neurostimulation is a viable option. End-of-line motor disturbances may benefit from intrathecal baclofen. Now, coming back to the case, the phase 2 of the CRP, phase 2 of the case, which was in 2024. Patient presented with increased pain in right hand radiating up the limb. The pain was severe in intensity with NRS 7 on 10. It was continuous type of pain and the nature was pin pricking, which increased on movements. There was no evidence of aerodynia or hyperalgesia this time. Blood investigations were normal. NCV suggested of carpal tunnel syndrome. So the case was consulted with orthopedic team regarding implant in situ and whether it could be the cause of the inciting symptoms. So the patient underwent implant removal in September 2024, and and the pain was subsided. The patient did well for another 5 to 6 months. Now the phase 3 started, recrudescence of CRPS. By revealed normal ESR and CRP. On DEXA scan, there was focal osteopenia in the right forearm. The patient was again managed with a repeat stellate ganglion block along with pharmacotherapy, which produced transient relief of around 1.5 months. This time in pharmacotherapy, we added amitriptyline and bisphosphonates as there was a regional osteopenia on DEXA scan. Patient was educated for mirror therapy and physiotherapy was also advised. Now I'll be discussing the evidence-based treatments of CRPS. Pharmacological therapies include gabapentinoids, antidepressants, amitriptyline, topical agents, and opioids. And among these, gabapentin has the highest range of level of evidence from systematic review down to case studies. The examination findings: overhead abduction of more than 90 degrees was painful. Apley scratch test, Needs test, Hawkins Kennedy test was positive. External rotation was painful, and there was a focal tenderness in left upper one-third of the arm. The right shoulder MRI showed type 3 acromion, subacromial bursitis, early rotator cuff tendinopathy, and acromioclavicular joint degenerative changes. These findings represent secondary structural changes commonly seen after chronic immobilization in CRPS patients. The cervical MRI reveals C5 to C6 spondylotic neural compression, which could be a possible nociceptive contributor, but could not account for vasomotor or trophic CRPS features. Now, there were two differential considerations at this point in time. First was secondary frozen shoulder, which is strongly associated with CRPS due to disuse, atrophy, autonomic changes, and neuroinflammation. Second differential was regional spread phenomena. Was the CRPS spreading to other limbs? And it is very well described in CRPS literature. But the shoulder involvement did not meet spreading CRPS criteria, which we discussed in the consensus earlier. It fitted better under the secondary musculoskeletal complication of persistent CRPS. And it was supported by the 2020 narrative review by El Hezbani, which highlighted several mechanisms as to why CRPS frequently coexists with shoulder stiffness. The mechanisms explained were prolonged immobilization, disuse atrophy, central sensitization and spread of neuroinflammation, and autonomic dysregulation around the glenohumeral joint. Now, coming to the interventions done for the shoulder pain. First intervention done was subacromial subdeltoid bursal injection, which produced 60% relief for around 20 days. It was then followed by glenohumeral intra-articular steroid injection, which again gave good relief for a month. And it was finally followed by a right suprascapular nerve PRF, which gave 80% relief for around 3 months. Now, October 2025, the nature of pain changed again. Patient was symptomatically better, but still complained of bilateral upper limb pain. There was again no swelling, warmth, or allodynia. However, there was anterior joint line tenderness in the shoulder and range of motion were less. At this point in time, we decreased the dose of gabapentinoids. Bisphosphonates were stopped because the course had been completed. Shoulder and wrist exercise were advised to be continued. And due to this characteristic feature, the new development in the nature of the pain, the patient was asked to consult cardiologist because the pain did not look likewise. On investigations, the ECG was normal, even echo was normal, but when the patient underwent TMT, it was positive for inducible ischemia, and the angiography revealed triple vessel disease. That was surprising for us too. Patient underwent CA With this background, I would like to highlight the study which predicts peripheral sympathetic function as a predictor of CRPS in patients with radial fracture. Prior work had shown abnormal sympathetic function, but unclear whether sympathetic changes are causal, secondary, local, or systemic. This study tested whether peripheral sympathetic dysfunction is present very early after trauma and whether it predicts CRPS1 development. This study took 27 patients with distal radius fracture. 4 patients, and they were followed for 12 weeks. 4 patients developed CRPS during the 12-week observation time, and 2 patients were kept borderline. They presented an incomplete clinical CRPS1 picture. And the result of the study suggested that the disturbances in the sympathetic nervous system in CRPS1 patients are systemic and not limited to the affected limb. This patient's recent coronary artery disease can be understood against the backdrop of this study, where early bilateral loss of normal vasoconstrictor reflexes are present. The coexistence of persistent CRPS and advanced coronary disease likely reflects a shared milieu of long-standing autonomic and endothelial dysregulation, with each condition capable of exacerbating the other. There is literature on CRPS developing after coronary interventions, but the reverse chronology is not reported. This is one case in which coronary artery disease presented later, and this presentation may be purely incidental. Now, as the patient had regional osteopenia, there is one study which is on clinical implication of regional osteopenia in CRPS. They took 116 CRPS patients, and out of those, 68 patients developed osteopenia in the affected limb. So this study says that CRPS-related regional osteopenia is a predictive factor for anticipating sympathetically maintained pain. Now, integrating all the layers, our patient had regional bone loss in the affected limb, and he repeatedly derived substantial pain relief from stellate blocks. So it would not be wrong to say that focal osteopenia in the involved limb is a clinical footprint of this dysregulated sympathetic bone axis and predicts good response to sympathetic blocks. Now, to summarize the clinical course, the case which presented as CRPS1 developed into persistent CRPS, had a good response to stellate ganglion blocks in due course. Regional osteopenia was found on DEXA scan, and it turned into a new subtype, which is CRPS with remission of some features, and it later on developed into secondary frozen shoulder, which was associated with secondary frozen shoulder. Now, I would like to summarize by saying that CRPS is classified under chronic primary pain now. CRPS is known to fluctuate over time, shows variable expression of Budapest criteria features. It transits from acute or warm to persistent or cold phases. In the first 12 to 18 months, the duration has been defined now. Early intensive multimodal physiotherapy and rehabilitation targeting both hand and shoulder should be advocated to prevent restriction of movements and contracture. The pharmacotherapy should be continued, and dosage optimization should be done accordingly. There is need for longer-term sympathetic blockade and neuromodulation if the cases are relapsing. And we need to address bone health also and cervical radiculopathy contributions too. Thank you.
Very well presented, Dr. Diya. Dr. Achal and Dr. Debesh, one small request. Actually, my student Gunjeet is not able to charge her laptop from the room from where she is presenting. The point is not working. So can we have both the presentation together and then we'll discuss it later if possible?
Yes, sure.
But
Let's
when
move to
she
the
will
next
present?
one.
No, I want her to present now so that even if her laptop is not working, she can go for discussion from the mobile itself.
Yeah, absolutely. Please
Okay,
ask her
then.
to share the screen.
Yeah.
Dr. Diya, you can
Yeah.
stop sharing.
Yes, ma'am.
Gunjeet, you can start your presentation, please.
Yes, sir.
Just go to share and then click stop sharing.
Yes, ma'am.
Yes, perfect.
Very good evening. I'm Dr. Mithilesh from Sir Ganga Ram Hospital, and today presenter is Dr. Gunjeet Kaur. She's our DNB resident, and she will be talking about intervention for pediatric knee pain. Dr. Gunjeet, please.
Good evening, everyone. I am presenting the topic of intervention for pediatric knee pain. So, this is a case of a 13-year-old male child who was known to have ankylosing spondylitis and HLA-B27 positive. He presented with a history of intermittent lower back pain and right knee joint pain for the past 2 years. Over the last 1.5 months, he developed progressive difficulty in walking, which was accompanied with frequent falls. The child also reported sudden onset, moderate intensity pain during ambulation and increasing difficulty in sitting position. There was no history which was suggestive of any systemic illness such as fever, cough, cold, GI disturbances, or any neurological symptoms such as headache, seizures, or altered sensorium. Also, there was no history of any preceding trauma. The patient now presented to Sir Ganga Ram Hospital for further evaluation and management of his worsening symptoms. On general physical examination, the pulse was 114 per minute, the blood pressure was 118 by 74 millimeters of mercury. He was afebrile to touch and weighing 33 kgs. He showed signs of pallor, but there was no evidence of icterus, clubbing, cyanosis, lymphadenopathy, or edema. No significant findings on systemic examination were seen except for the CNS system, which showed a deep in lower decrease in power of lower limbs, grading 4 by 5. Deep tendon reflexes were diminished in both lower limbs, and plantar reflexes were bilaterally downgoing with suggestive muscle dystrophy. There were no signs of meningeal irritation, and the pupils were equal in size, reactive to light bilaterally. So before coming to the pain clinic, patient was under pediatric department. Supportive, he was being managed supportively. All basic investigations were done, including CBC, LFT, RFT, which mostly were in the normal range. Also, the inflammatory markers were unremarkable. CRP was negative, ESR of 9 millimeter per hour was seen. Additional tests were also done, which didn't show any findings. So some special referrals were sent, such as to genetic medicine. Genetic workup was planned if there was no improvement. A referral was sent to ophthalmology because he was having increased lacrimation, but the fundus examination didn't show anything. Referral was also sent to orthopedics department. MRI right knee was done, which showed elongation of inferior pole of patella. There was new bone formation between the patella and overlying tendon, which was extending along the patella. The findings were suggestive of chronic strain or traction related osteocartilaginous injury, which was likely Sinding Larsen Johnson syndrome. So, multidisciplinary evaluations were sought before coming to the pain department, like rheumatology, psychiatry, neurology, but nothing was diagnostic. MRI screening was also done, which was normal. Nerve conduction velocity was done, which was within normal limits. Electromyography revealed myopathic changes in both proximal and distal muscles of upper and lower limbs, but it was without any evidence of denervation or myotonia, which suggested myopathy or muscular dystrophy. A 2D echogram was done, which was normal, and in view of persistent pain and restricted mobility, the kid was referred to the pain relief unit. So, in nutshell, there was no proper diagnosis clinically before coming to the pain department. The patient was having severe knee and plantar pain. The kid stopped going to school due to severe pain. The kid was almost bedridden since 2 years, and only the MRI was suggestive of a syndrome, that is Sinding Larsen Johnson disease. So the issues we were facing were severe knee pain, which was bilateral in nature, which was aggravated by a movement. NRS score was 10 by 10, and the plantar fasciitis pain was there. So a little bit about Sinding Larsen Johnson disease. It is most commonly seen in the age group of 9 to 17 years. It is most commonly seen in males. It is spontaneous. It is usually without any sudden trauma, with the onset near the upper pole of patellar tendon. The pain may be progressive or chronic in nature, more than 3 months. It is usually associated with sports activities. There's antalgic gait even with the limb. And there are some aggravating factors like climbing or descending stairs, kneeling, long distance walking or running, and even prolonged sitting. The pain can be unilateral or bilateral. On palpation, there is usually tenderness around the inferior pole of patella. The range of motion is usually normal in these cases. The clinical feature of this entity are non-specific due to variety of symptoms which are described in the cases. There are no special tests available for the diagnosis of disease. X-rays are usually not very useful. There's a small area of heterotropic ossification at the inferior pole of patella. On ultrasound, there is cartilage swelling, patellar tendon thickening, and lower pole patellar fragmentation, which often reveals some changes. But the MRI, which shows critical features like hyperintense signals, irregularly shaped patella, intratendinous bone fragments, and extensive edema that may not be visible through any other imaging methods, which are usually the diagnostic criteria of Sinding Larsen Johnson's disease. So we planned an ultrasound guided right-sided genicular nerve block, plantar PRP, and the Baxter nerve block. After obtaining written informed consent from the parents and under strict aseptic precautions, the kid underwent ultrasound guided nerve block targeting the right genicular nerve, platelet plasma injection into the right plantar fascia, and Baxter nerve block PRFA was given. Post procedure period was uneventful. Post procedure, the patient had pain relief of more than 70% on day 1 and around 80% on day 2. Physiotherapy was started. The arch fit sleeper was given to the kid, and the child was able to walk in a few days. And patient was advised physiotherapy for 30 minutes walk daily. Arch fit shoe was advised. Patient was given pregabalin tablet and paracetamol sustained release tablet for few days. Just a second. Now I'll be sharing some videos regarding the block. First is the Baxter nerve block.
I'll be discussing it also again later if required.
There's another video regarding this is a genicular nerve block. And I have one of plantar fasciitis video. Sorry. These are the same videos, but these are without audio. Sir, over to you.
Thank you, Gunjeet. It was a nice presentation. Over to Dr. Diya and Dr. Debesh. We'll discuss all this after their discussion.
Mithilesh sir, you can finish the case and then we can discuss both
Okay.
together. Dr. Mithilesh?
Answer.
Dr. Mithilesh, can you hear us?
Yes. The voice is not clear, Answer.
I was asking Dr. Mithilesh if he wants to present first. Actually, my internet is giving little trouble today. Can you hear me fine?
reported.
Sorry.
Hello, anything you are
Yeah.
telling?
Yeah. So regarding the first case, the third time he presented, you did not do, you just did stellate ganglion block and it was not followed by RFA, right?
In the first time you did RF because initially, because the patient responded to a single block, first the diagnostic block that given was he was responding at least 6 to 7 days. The
Mm-hmm.
interesting case is that in this case, every time he responds very well. And
Hmm.
the another thing is that he does uh, all the physiotherapy, everything very nicely. And
Hmm.
that's the reason that after I think 3 or 4 blocks, okay, we thought that also will give the PRF.
Mm-hmm.
And the patient was free and on follow.
Mm-hmm.
And I think 1.5 year, 2 years. So it was really strange. I had that thing, I missed that video also.
Mm-hmm.
He was having that hyperalgesia, allodynia, everything was not there. Not, matlab, it's completely out of the way. So
Hmm.
mostly the things has been sorted for what the patient was for that. So during that time,
Hmm.
the strange thing in this case was after matlab, on 1.5 year, something that pain came back because initially, normally the pain that in some cases we see that pain might persist at certain level and then goes on like that. But this is one case that says that it is a totally pain-free 1.5 year. It's out of this. But somehow then pain started and the feature is similar,
Hmm.
but with certain feature not there.
Hmm.
Sort of recurrence you can say it is. But
Hmm.
so that's why I thought to follow up this case, what is
I
going on.
think, and we need to think of other reasons as well, like after removing the implant, pain got better, and
Yes.
then there were adhesive capsulitis, which was there.
So these are basically the second. Normally, if you see as a my in the discussion part is that
Hmm.
many a times every time you do for physiotherapy and all, these are the secondary changes that might happen. And
Hmm.
also, if you keep in mind that it is not only the one that pain is there because the patient is coming like this. So
Hmm.
initially that one it is because I was seeing the patient from hall and I can remember how with allodynia was there. The
Hmm.
second patient was confused. He was basically simulating the same symptom as it was previously. But
Hmm.
when I examine and the touch it, there is no hyperalgesia. There is. He was, if you touch him and doing this, somehow the pain is coming this area or is basically central sensitized, you can say. Matlab, because he has
Hmm.
restricted movement
Hmm.
somehow to protect it because that maybe you can say the second time then when the pain occur, not the first time. But
Hmm.
the first time he was completely all right for I
You
think
had
one and a
typical
half year.
features for
He came back
CRPS,
at
but
one
we
and a half year.
know when
The second
CRPS
time he was extra
presented,
precaution.
you may not get all the features, right?
Exactly, not the features, and he tried to protect, overprotective. That lead to that initial adhesive capsulitis and also a bit of bursitis also.
Hmm.
And he responded.
Hmm.
And the first initially the that second important thing is the placebo. In this case, I must say the effect of placebo also. In
Hmm.
that case, sometimes the if you say sometimes if you give a suppose it is a pain is there, the moment you give a block,
Hmm.
then immediately the pain of 9 is totally gone and the immediately the psychological effect and everything was gone and
Hmm.
become all right. But clinically, apart from clinically, evidence is there when we went for the in this case I advised for the DEXA scan and osteopenia because it's second time it is coming up there. So normally orthopedicians send us by doing this EA. We don't advise for this.
Hmm.
They usually do the bone scan and the everything and they stamp it as EA. But this time we thought ki again repeat, let's see ki whether it is the same osteopenia is persisting or something developing or there. But it was there and then he responded. So basically there is multifaceted presentation of CRPS that I think that we have to think of.
Hmm.
And also the importance of apart from the interventions and medication, many important things as physiotherapy and all the advice that normally give it. And I think subsequent also management that we are taken care of, and he responded well.
Hmm.
Now he has psychological also good, but the recent some development is there. So I think I had to discuss whether there is something else to correlate with that
Hmm.
it might some underlying maybe the coronary disease or something that might It may be related to the stress or something, because normally you have seen the patients are basically depressed, or maybe because it is chronically they are coming to a
Yes,
clinic.
yes.
This is one thing.
So you did pulsed RFE of stellate ganglion, like you did ultrasound guided that in longer coli fascia. You did the PRF?
Ultrasound guided. Actually, now if you say it is, maybe you can say it is a middle cervical ganglion, because exactly to reaching up to the stellate ganglion by the ultrasound guidance is a bit difficult. But we did in that, and as initially it was responding, I did in that
At C6
same
level.
ultrasound guide. C6, C6 and C7. Normally, I try to put my needle safely if I can go bit up down. Even if the C6 is go, and then try to follow the longest coli and as much as down without injuring the nerve root and vertebral artery. We try to keep the needle bit of down so that as close as possible we can keep it.
Raj sir, you have any
And that's
questions?
how I
You have
think
any
he responded.
comments? Dr. Raj?
I think they.
Any experience of sort of recurrence is something that is for me it is new. Most of the time it is a persistent, but something already recovered and then coming back.
Or stays like at a particular level of pain. Either the pain goes down with time or it stays like that. It's very unusual to have new symptoms after some time and the pain going up.
Exactly. But psychological and the mindfulness, those things, when the patient respond, develop, it helps a lot that I have seen. But sometimes we feel that yes, this condition is persisting in some way, but this is something.
Yeah, I have tried, but still it के कुछ ज़्यादा अच्छे results आए नहीं. I'm not a fan of sympathetic blocks for or neuropathic pains.
But
Ma'am, can I say something?
Yes, yes, please, Dr. Manoj.
Sir, why can't we do T2, T3 sympathetic RFA in this case? Actually,
see, it is always a T2, T3, because if it is not responding to still, because the whatever the evidence, see, normally as per the evidence or as per the clinical evidence that you have seen, even if the patient has responded to stellate ganglion RF and or pulse RF, because all the things has been there, and it has been seen that T2 T3 is not also it is that a T2 is 100% giving the relief, or the pain has gone. So I was thinking of one sort of thing for to go for T2 T3, but as per the literature, even the T2 T3 also has been seen to provide. Yes, it has provided relief in those cases, because if it is a pain of upper limb, then T2 T3 can be diagnostically done and then followed by RF. But the results is not promising to say it is 100% for A. Again, the result is less than 50% as per the studies. But practical experience, I cannot say, because how many somebody has done T2 T3 for A. But if it is responding to something, then that is worthwhile doing. Because
Dr. Debesh, we have never done stellate ganglion PRF or something for upper limb.
I have also not done
CRPS. We always do T2, T3
sympathetic RFA.
conventional RFA, and does wonderfully well.
Yeah, that's what I was wondering. How do you do
stellate
stellate
ganglion is a
PRF?
big ganglion. If you see, it is around 1 inch. If you go to the if you go to the anatomy of stellate ganglion, it is around 1 inch in length. Right, it extends from C7 to T1. Now, if you do PRF, at what point you are going to do PRF, and how do you select that PRF with a 20 gauge needle, which is not an ideal situation. Also, it never extends to C6 level. Stellate ganglion is always at C71. So, doing a block at C6 is okay. Doing PRF C6 is not a best technique for doing upper limb sympathectomy. It is for head and neck sympathectomy. And the other big advantage with 223 is you are always can give very good conventional RFA at T2, T3, 2 level. And when you do 3 lesions, they are big lesion and you get very good sympathectomy. So for last at least 12 years in my practice, I have never done stellate ganglion block or RFA. We always do T2, T3, conventional RFA, definitely with the diagnostic followed by RFA. And our results are more than 90%, maybe 95%. Very rarely that we land into failure. That is a standard practice at my institute. And I always a big fan of doing conventional RFA because stellate ganglion, as I told you, is a big identity. Doing pulse RFA with a 20 gauge needle, I don't know how much it is effective, and that too at C6 level, because anatomically it is not present at C6 level.
I do agree, because that same thing, I do agree with that, because obviously it is not the stellate ganglion that is, it is, if you are doing at the C7 even level also, that's the reason that I didn't do or never do.
And even then, if we do say stellate ganglion RFA for head and neck, so it is well described in literature, and but we practice also. You have to do conventional RFA at 3 level, at the body of the junction of the body and the transverse process, one in the middle, one end up, and one down. So you put your needle in the middle, go up, go down, and do 3 lesions, है and that conventional RFA gives very good results for stellate ganglion also, because it's a big ganglion and you have to do at multiple sites, and you can go medially also.
I got your point, sir, but the point of discussion is not here regarding the stellate or a T2, T3. It's regarding the recurrence of that symptom.
So no, we were discussing that, coming to that also. So this was about the technique, and
but you rightly
secondly,
said, because same thing, as you said, stellate you cannot do RF, and ideally T2, T3 is obviously in that way.
and like these patients of CRPS, they are very much with huge central sensitivity and in a fearful stage, because of this CRPS, is a very dirty pain. And unfortunately, not many people are able to treat it well. And patients, come to your clinic also, our clinic also, with a lot of pain and psychosis and all this. So if you treat them of their pain, still they carry that burden on their mind. Anything happens, they still jump into that. Immediately they will jump into that scenario. And as you said, you just did stellate ganglion block and patient was 90% happy. So it itself says exactly. So this is and this is always if your patient is asking for that, you think that it is a cycle rather than not doing anything. So it may not be that our CRPS is it was relapse or not, we don't know. But yes, these kind of treatment for patients' psychological benefit, they are wonderfully well.
I think take-home message is like, if the patient of CRPS come, we need to think of recurrence, central sensitization,
yes,
intervention, and multimodal therapy should be the target. And
Yes,
let's move
but
to
the
Dr.
evidence is also there.
Mhm.
Means if we go through the literature, and we have done also in 5-6 cases of upper limb CRPS, but we are doing this pulse RF at C7 level, and we have done in 5-6 cases with good result, and there is evidence for this stellate for upper limb CRPS. I will share
yes, there are a lot of evidence.
Yeah.
There is a lot of evidence.
Actually, see,
C7 is
It is
fine.
not that
C7 is okay.
it doesn't have evidence. Yes.
but the main thing, if you look for the ear also, it's not about the only the pain. That is basically, if you say the motor, basically I mean that the how the patient is doing the physio or following that.
Exactly. The
And
multimodal thing.
one more question, Dr. Debu. What was the dose of bisphosphonates? What was the dose of bisphosphonate that you have given to your patient? If patient was showing sign of osteopenia or something, what is the how we treat that in a patient for CRPS?
So in this case, you've started with 70 mg, and I think for normally give for 2 months.
No, 70 mg daily or weekly or what?
Yeah, weekly.
Weekly, the conventional dose. So I think in CRPS, where you have osteopenia, which is evident on your bone scan, the dose is much higher for treating a CRPS. It is not your usual dose that you give. I think it is monthly dose of IV injection or something like that. There is a protocol, Dr. Anchal, if you can share sometime that because usual dosing of CRPS, this Eldronate and all these is not helping. It has to be high dose for 3 to 6 month IV. So,
Sir, I think the high dose whatever is there, but it is I think not fixed protocol because
I agree.
it's
But
a
the
common.
doses are much higher as compared to that we give for 70 or 150 milligram per month. The doses are much higher in CRPS, which is documented osteopenia on bone scan.
Maybe
This is what I want to say.
we can put this topic for one of our journal clubs and discuss.
Yes.
What's the evidence of it? I'll write it down and probably we can have this discussion in one of our coming.
This is very important regarding the dose of bisphosphonate in CRPS.
And the problem what is happening, sir, is that something you are doing because as you said, you are experienced of more than a year. Obviously, you have dealing with so many patients. When you suppose you're doing something you've done by your experience because you are seeing something from your experience and something is not there in literature or something not you can prove why you suppose because the dose which has been selected in this basis also responded, the higher dose has been selected based on that it is not responded or some group of patients they had done some research.
We will
and
discuss on
found
that. This is a very good topic, carry on topic, how
this
to
can
treat this
be
osteopenia. Yes.
because
So Dr.
now
Achal will keep this for further
We will
discussion.
keep that
It's a very good
one
topic.
of our future journal
because
clubs.
True.
Yeah, Dr. Mithilesh, can you proceed with your?
Yes.
Ma'am, may I say something, ma'am?
Yes, please, Manoj.
Yes, Manoj, please.
Ma'am, actually, what happens is in private practice, if one of my patient was typical CRPS patient, I did diagnostic block. He got very good relief, but he didn't turn up again. It happened
so what do you
in
want to
private practice.
so what do you want to turn
Demo
up
के पास भेज दो AIIMS में.
no Manoj, what do you want, he should be okay na.
Yeah,
Then
can you see my screen, ma'am?
Not yet. Yes, we can see. We can see your screen.
Okay. So what I wanted to highlight in this, Gunjit has already presented well. Okay, so it was a child, a 13-year-old kid whose knee pain was bad. For 2 years, he has shown more than 20 doctors, pediatrician, ortho, rheumatologist, psychiatrist, everyone. Issue is, kid is not going to school. When it was referred to pain clinic, everybody started asking, what is your diagnosis? What is your diagnosis? Because everything means inflammatory marker were within normal limits. Clinically, it was like everything was involved. At this age, generally, we don't expect degeneration, osteoarthritis. There was no symptom suggestive of any infection. Child is not giving any history of any trauma. He was playing, but not a proper athlete. Also, we cannot say that it was like a cyclist or athlete knee, and it was tender everywhere. It was like full knee was involved. We came to this diagnosis of sending Larson, though it is very rare, incidence is less than 5%. But when I was preparing for this session, I came to know that if a kid is athlete, it may go to up to 25%. But this was a MRI finding. In our normal day-to-day practice, I don't know how many are comfortable or affording MRI. So clinically, we were not able to make any diagnosis. But what I offered is, since it was a knee pain and it was on movement, my first offer was genicular. Let the kid have a pain-free period for some time so that we can, if we at all want to investigate more. Plantar fasciitis was obvious. It was very painful. It was clinically present there, and we saw the plantar fascia thickness in ultrasound also. So that was okay. Baxter nerve, I just want to make 2-minute comment over that. It is a branch of inferior plantar, or we can say inferior calcaneal nerve to this, and this supply, it is a mixed nerve. It supplies to sensory to calcaneum and plus to motor to the uh, abductor minima. So I block it for two purposes. One, the PRP pain is less. Second, this calcaneal pain of plantar fasciitis also, even if you don't do PRP, I have seen in 2 3 patients just by Baxter nerve block. I do diagnostic followed by pulse radio frequency at some higher temperature, 50 degree for 3 cycle. Results are good. For I will be publishing it soon, and results are good. So in this case also I have done. Luckily, I will say luckily, because we were lacking in diagnosis and there was no relevant thing in hand, but it was a purely pain relief procedure which we have done, and the results were very satisfactory. That's why I told Ashu sir in last also that this child is taking all sorts of medication, pregabalin, gabapentin, and this rheumatologist have given so many disease modifying drugs. And HLA-B27 was positive at the beginning and it came negative at the end. Only diagnosis which was possible on ankylosing spondylitis was enthesitis. Enthesitis is wherever tendon or ligament is joining, all the area are painful. That is one diagnosis. For that also, if we do genicular, it is helpful. I think we don't have much time to discuss everything. I will just, for students' sake, this one slide I just want to discuss, that if we get any knee pain patient, mostly it is adult which we are seeing. In pediatric also, knee pain is equally important and equally incidence is there. So we divide knee into 4 compartments: anterior, medial, lateral, and posterior. These are few very common reasons for the pain in those particular compartment. I have mentioned the diagnosis of only adolescent. I have not covered the adult part in this slide. Our normal test, the which we are examining the knee, we are doing anterior drawer, posterior drawer, Lachman, and palpation. We will get mixed finding in this. So we should have, even when consulting a pediatric patient with knee pain, we should have a backup that these are the diagnoses possible. Once we know it is possible in pediatric, we will look for it and then only we can manage. I think I'm ready for any questions. If I have so many slides, I can keep on going, but time is less. So by keeping this slide in the background, I would request any questions or doubts.
Yeah, people can type in their questions if they have. But this is a very good chart, especially the previous one as well. I have treated a kid with that was Baker's cyst. He came with posterior knee pain, and
Yes,
he
ma'am.
already had MRI. He had big Baker's cyst. So
Our
it was just
pediatric
aspiration
rheumatologists
followed by
just refer for
steroid.
that purpose only. Yeah.
So, but it was a 14-year-old kid, so I was surprised that such a small kid has such a big Baker's cyst. So it was just aspiration followed by steroid. Yeah, we do get kids with knee pain, and diagnosis is, I think, the most important thing. Yeah, correcting. So how long the pain lasted, sir, for
Ma'am,
genicular?
it's 3 months, and a kid has not come up to Delhi after that. And the best part was his parents and his grandparents, none was ready because they have lost hope in our treatment module. And the best part is, next day I was also not that satisfied that out of way I have done the whatever pain relief method we know in adults. I have put all those in that kid at a single go. After 24 hour next day, what he asked, that was the most satisfactory answer. Sir, which sports shoe I should buy?
Mhm.
So that has finished. After that, I
For a
have not gone to see
bedridden,
that
yeah,
kid.
for
Yeah,
almost bedridden kid, this is the.
true.
The immediate pain relief that got that.
So did you use
So
steroids along with local anesthesia for
we did
genicular
it
nerve block?
in Exactly.
Ma'am, I do RF in almost all. I don't use a steroid. I do RF for all the genicular nerve.
No, so it was just a genicular nerve block, or it was a RFA?
RFA, genicular nerve RFA, Baxter
Genicular
nerve
nerve
RFA
RFA,
with
ultrasound
PRP in
guided.
plantar
Okay.
fascia. Yes, ma'am.
Got it, got it, got it.
Did not use any steroid while using PRP.
No, sir.
That's
I'm
what I
not using.
wanted to ask you, combining the both.
No, sir.
And single setting PRP or matlab any
Single sitting, sir. Patient has not come yet. It is almost 3 months. We have told you that you can come whenever you want. I have not given any deadline, and I have given him only 50 milligram pregabalin at night and paracetamol sustained release once daily. That was the only medication he is on.
Okay. Ashu sir, any questions?
Yeah, I'm waiting for Ashu sir come in.
भाई हमारे लिए तो नया एक्सपीरियंस है,
Sir.
तो ज्यादा कमेंट है नहीं.
Sir.
Sir, why did you call her?
We are, all the pediatric cases when it comes with headache or knee pain or anything, it's a new thing. Like I'll be sharing.
Actually, pediatric patient में ना problem क्या है कि in our experience also, doing intervention is a very difficult task.
True, sir.
Parents will not agree for anything. You tell them anything, whatever you want, they will not agree. So they're and kids will be okay, but mother, father, they are
yes.
very hyper. So
Yeah.
usually I tend to avoid